And welcome, good morning and welcome to Grand Rounds. We're very excited to have Dr. James McCabe give our first Grand Rounds of this academic year. A little about Dr. McCabe. He did his undergraduate work at Bowdoin College, where he graduated magna cum laude with honors, then went on to receive his medical degree from Yale University. He completed his internal medicine residency and cardiology fellowship at the University of California, San Francisco, followed by interventional and structural interventional fellowships at Brigham and Women's Hospital. He also completed a certificate of advanced training in clinical research at UCSF. He is currently an assistant professor of medicine and the medical director of the UW Cardiac Cath Labs. He's been honored throughout his career as a physician scientist, and his current research focuses on quality and performance metrics for cardiovascular procedures and their use in public reporting. Additionally, he's been involved with many publications, meetings, and committees, and currently serves on the Washington State Public Reporting Committee for percutaneous coronary intervention and chairs the PCI Analytics and Report Subcommittee. Please join me in welcoming Dr. James McCabe as he gives his talk today entitled Coronary Stenting and the Impact of Report Cards on Public Health.
All right, can you hear me? Seems like they're going to turn this on in a sec here, but always hard when the introduction of the person introducing you is way more impressive than your introduction. Just bear with me. So we're going to spend the next 40 minutes or so talking about, there we go. We're going to spend the next 40 minutes or so talking about public reporting, transparency, and its effects on behavior changes among physicians in particular. And we'll look at it through the lens of coronary artery stenting. So let's make sure this guy works. Okay. All right, here are my disclosures. I have no financial disclosures to make. Let me start with a question. Instead of spending the next 40 minutes talking through these slides, what if I said to this group, you know, I'm going to give you a quiz. I'm going to pass out a test, and I'd like you all to take it. At the end, I'm going to grade your test, and I'm going to tell everybody how you did. Right? I'm going to just line up your names on a sheet of paper with a score next to it. Then I'm going to send it to your friends and your colleagues and your coworkers, and you're just going to have it, you know, we'll just all see how we each did. By the way, there's two tests. One of them, even an interventional cardiologist could complete. The other, not so much, right? And if you are feeling ambitious and you take, I recognize that one of these tests is harder than the other, and if you take the harder test, I will give you an extra 10 points on your score. You get a 70, I'll give you an 80, because I'm feeling generous, right? So let me ask you this. How many people in the room are going to take the harder test, right? You know you get a little extra bonus on the end, but everybody's going to see your score. Right? And it's a bit of a pain to try and explain, well, you know, in calculus, like who does calculus anymore? It's not important, right? It's hard to explain away an F, right? And so this, I think, contextualizes, at least to a degree, what we're up against when we start talking about transparency and public reporting, and is an important factor because human behavior among the operators is a really big deal when we start talking about public report cards. Okay? So here's our agenda. We'll talk a little bit about background. We'll do some metrics for the report cards. What do we use to inform quality decision making? We'll look at the national experience of other states and how it might apply here. And then I'll give you what I believe are strategies for potential improvement. Okay? So first off, it's just a little background. Coronary stenting, the formal name is percutaneous coronary intervention, or PCI. You'll hear me refer to it as PCI. It's also called angioplasty. Fundamentally, conceptually anyway, it's the idea of opening blocked heart arteries with this little metal scaffolding tubes called stents. And that is what I do with a large part of my day. Interventional cardiologists do these stents, and there have been some distinctly bad apples over the last few years. Very notable individuals who have really made bad choices to perform in a way that fits their needs and their financial needs and not necessarily their patients' needs. Mark Madej being probably the biggest example of this, but there are others. There's a guy in Ohio, and then somebody in the Pennsylvania area. This has become, it's a little bit of a repetitive news cycle. At least it was maybe 5 years ago, of one over and over, a couple of people here and there who are choosing to make bad decisions. And I think this has led to a certain context in the national media, right? A doctor as predator. Stay away from your doctor. The one word that'll save your life is no. And so in this setting, you can see why there's a really important argument for public reporting, right? That public reporting allows for transparency. It accelerates adoption of best practices to the extent that those exist. It provides teeth for quality monitoring that is sort of, I prefer that it not be a stick in this scenario, but it often is. And the Hawthorne effect, which, as you probably know, is simply when something changes just by watching it or looking at it, the effect of studying something. And then it theoretically promotes informed consumer choice, though I think the data for that are really scant. But at the end of the day, you need to have metrics that you actually report on, right? How do you judge quality? We want to give somebody a report card, but if we don't know what to test, then it's awfully hard to do. So there are a number of different reporting agencies out there, but they tend to focus on a few different quality measures when it comes to PCI, right? They fall into two categories: outcomes, risk-adjusted mortality, right? That's probably the most sensational. It gets the most headlines, and is one that we'll focus on primarily today. But there are others. There's readmissions, which has been difficult to do as patients move from one hospital to another, but using billing data, that is becoming a little bit more available as a quality metric. And then there are processes. Door-to-balloon time is kind of a famous one. This is for patients who come in with a particular kind of heart attack called a STEMI. How fast do they move through our system into the cath lab and have their heart artery open? Right? That used to be really important. These days, it's sort of been dropped as a pay. The pay that the hospital gets used to be tied to door-to-balloon time. It was that important. That no longer is the case. And then there's something called appropriateness, which is a bit about decision-making. And we're going to dig into this one for a second. So different reporting institutions use different metrics. They're not consistent, but by and large, they fit into these kind of bins. Right? So let's look at appropriateness for a second. Appropriateness grew out of these sort of exposure of physicians who are putting in stents unnecessarily. It's a measure of quality decision-making. It's how you're thinking through what you're about to do. And really, it's meant to explore overuse, right? So are we putting in stents in scenarios where there's little or no expected incremental benefit to the patient? This is work by Steve Bradley, and who is a former physician here now at University of Colorado, Chuck Maynard, who's on COPE, myself, and some others, looking at the indications for stenting in Washington State over the last number of years. And you can see there's probably a lot of things that feed into this, but around the time that this idea of appropriateness really came to bear, you can see that patients who were getting treated for stable angina, which is this black line right there, really started to go down. These are the scenarios where things are elective. There's a lot of choice involved in what's the right treatment modality. It may be where some of the abuses or overuse was taking place. And so you can see over 7 years, there's a 46% reduction in Washington State in the use of stenting in elective scenarios, right? This is you or me coming to your doctor, relatively healthy, some chest pain. This is not an emergency scenario. This is not a heart attack scenario. Right? So the AUC has really been helpful in sort of trimming the fat off of the system, right? Making sure that we're limiting our use of stenting in low-risk scenarios where it may not be necessary or where it may not be expected to help our patients. But we're only talking about decision-making in one direction so far, right? We're not talking, or we don't talk nationally, about the other direction, which is decision-making in really complicated or difficult scenarios. And so what about those? Well, here's one thing that I would like for you. I'm not going to go into a lot of data on this, but I'd like for you to take this at face value, if you would. which is that if you are really sick with a heart problem, if you have out-of-hospital cardiac arrest, cardiogenic shock, a STEMI, ischemic cardiomyopathy, in those scenarios, having normal blood flow to your heart is better than having less than normal blood flow to your heart. Okay? That's just a fundamental belief that I hold, and I hope you'll buy that for today. Right? This was shown years ago. This is now 17 or 18 years old, Judith Hochman in the SHOCK trial, where patients came in cardiogenic shock. They were randomized to urgent revascularization, that is, getting better blood flow to the heart, versus medical therapy only. People who got urgent revascularization did better. It's a highly mortal condition. A lot of people died right out of the gates, right? But your chances of survival were better if you got revascularization, and it didn't matter how you got it. Stenting in 1999 is a little different than it is now, but stenting and bypass surgery were equivalent in this study. Point is, more blood flow to the heart when you are sick is good. Okay? So, I want to introduce to you this concept of commission versus omission when it comes to decision making. Right? We've been talking about the appropriate use criteria and overuse. Really, we're talking about areas of commission, right? We're doing something to someone where it's maybe not necessary. Problem is that avoiding an appropriate or indicated procedure when it is beneficial may also be inappropriate, may also be an act of omission. The difference between these two is that errors of commission are really easily tracked. Right? We know who gets a stent. There's billing data, there's clinical registry data. There's lots of ways to know who gets treated. What we don't know is who has the disease state. Right? We don't have disease-specific registry, clinical registries. There's some billing data, maybe, depending on how you like to use that. But by and large, we don't know how many people have shock or how many people have out-of-hospital cardiac arrest who may have warranted therapy and didn't get it. It's very difficult to track. Doesn't mean it's not a bad decision to not treat someone, right? So as we look to Washington State, as we look to our home territory, the questions are, I've just told you that PCI in the sickest patients confers a mortality benefit, right? I hope you'll believe that treating sicker patients is harder than treating healthy patients. So as a state that's just introduced public reporting, have we changed the game? Right? Are we going to affect errors of omission among our operators? I think that's a critically important question that we need to ask. So let's look at the national experience to sort of help inform us about what we might expect in Washington. Right? Here's the country. First state to report on PCI outcomes nationally or within their state was in New York in 1992. This was not done out of largesse. There's actually fascinating history around public reporting in New York. It was actually Newsday filed a Freedom of Information Act with the state Supreme Court saying that they wanted the mortality outcomes of every surgeon who operated in that state over the prior year. And they won, and they got that mortality data, and then they just published it en masse in Newsday. Right? Here it is. Dr. Jones had 42 deaths. There's no risk adjustment. There's no consideration of statistics. It's just a list. Right? So New York kind of recognized the cat was out of the bag and thought that they could do a little better than Newsday and started publishing risk-adjusted mortality for surgeons and interventional cardiologists following cardiovascular procedures as of 1992. So what happened in New York? Well, let's go back to that SHOCK trial that I just told you about. This is a sub-study of the SHOCK trial. And when they separated the states, the colors are all funny here, but non-New York is black in this setting. New York is blue. When they separated the states, they saw, New York had a little bit less revascularization with PCI in the setting of shock, but almost more incredible was that though the rates of CABG remained the same, the average time to CABG in non-New York states was 10 hours, and in New York it was 101 hours. Right? 4 days later, a little Darwinian kind of exceptionalism, starting to select out maybe those patients who are a little bit lower risk for a bypass. Just one potential line of evidence. Going further, looking at the mortality outcomes, so if you got a PCI for shock in the shock trial in New York, you had a better mortality rate than if you were in a non-New York state. So maybe New York is performing PCI better than other states now that there's public reporting. Similarly, CABG mortality outcomes better than in New York than in non-New York states. Maybe they're doing CABG better in New York than in other states. However, the overall mortality for shock patients in New York went up. Right? Higher overall mortality in New York than in non-New York states. It's not conclusive, it's not causative, but it is just a data point. Right? Looking overall at the mortality statistics over the first few years after public reporting came to pass in New York, what we saw is that the mortality following coronary intervention went down, right, from 0.82 to 0.58. Maybe they're doing a better job. What we also saw is that the people who got stenting much less frequently got it for shock. Now, we don't know how many patients had shock. So maybe there's a secular trend in New York where fewer people have cardiogenic shock. Therefore, fewer people who get stenting get it for cardiogenic shock. That's possible. But certainly seems like maybe there's a little sort of suggestion that operators are choosing not to treat really sick patients and their aggregate mortality might be getting better. It's one way to think about it anyway. So let's move forward. 10 years go by before the next state starts public reporting, and that was Pennsylvania in 2002. Pennsylvania never really did much with their public reporting processes. They've never published much out of it. There's not a lot of information that come out of there. But the next year, Massachusetts joined the game excuse me, and began public reporting in 2003. Sorry about these colors not showing up very well. So let's look at what happened in the couple years after Massachusetts started doing public reporting of PCI outcomes. Well, it turns out that the percent of patients getting revascularization with PCI or PCI or CABG for shock declined by 43% for PCI and 37% for CABG, right? So, again, we don't know the denominator. We have no idea how many patients in Massachusetts had shock. What we do know are these little trends, right, that start to say, okay, people are looking at our mortality outcomes, and now the people who are getting treatment are less frequently have cardiogenic shock. They're less frequently treated, perhaps, than in other states. And the reason for this is not subtle. Turns out that when the lay press loves blood, and they will, this is a below-the-fold front page article in the Boston Globe, 2005. For those of you who don't know, Tom Brady, suspension invalidated today, just FYI. I am from Massachusetts, so 10 years later, go ahead and applaud. Go ahead and applaud. All right, so he's, even in 2005, he was undaunted. This is front page article in 2005 that University of Massachusetts had suspended its entire CT surgery program. They're the highest volume CT surgery program in the state of Massachusetts. They suspended their entire program for 7 months because they were the first hospital to be identified as a quote-unquote poor performer in the Massachusetts public reporting process. The statistics suggested that they had more deaths than they ought to have. And so they stopped their program hard. And it came out on the front page. This was big news. This has not happened in Washington, despite public reporting having started a couple of years ago now. But there's nothing to say it won't, right? This has a really big potential impact on hospital administrators and on the psychology of the operators themselves. Nobody wants to be on the front page for something like this, right? So, and when we looked at the negative outlier hospitals, the quote-unquote poor-performing hospitals in Massachusetts, in a state where there's already a suggestion that they were treating less sick patients, those hospitals that had been identified as poor performers treated even less sick patients, right? So the expected mortality of their patients in the subsequent years went down further. Not the actual mortality. This wasn't about how they performed. This was about the case mix index, right? What do the patients look like in aggregate? And you see that all their patients are getting less, the ones who are getting treated are getting less sick. And I've just told you that stenting works when you're really sick, right? And that we're trying to trim the fat and not treat healthy people necessarily, right? That's a complicated story around that, but in general, one would expect with other secular trends that the case mix index, that the aggregate population being treated should be getting sicker over time as we focus on people who potentially derive the most benefit. That's not what we're seeing, and we're seeing in Massachusetts that those 4 hospitals that have been identified over the years as poor performers are getting even more risk-averse or gun-shy, potentially, right? And just not for nothing, the 4 hospitals in Massachusetts, University of Massachusetts was first, St. Vincent's, which is a large tertiary care center in Worcester, was second, Beth Israel, a Harvard-affiliated hospital, was third, and Mass General, another Harvard-affiliated hospital, was fourth, right? These are not, community hospitals or little joke hospitals. These are big deal hospitals. So Karen Joint, who's a wonderful outcomes and policy researcher, a friend of mine, published this in JAMA a couple years ago. She looked at CMS, Medicare data, and looked, Massachusetts is the filled-in circles, and the non-Massachusetts states are the open circles. And she looked at the introduction of public reporting right here. This is the first report, came out in 2005. There's a little lag time between the 2003 data and 2005. First report came out, and she looked at everyone who had a billing code of acute myocardial infarction, right? Sick patients, theoretically. And what percentage of those people got treatment? Well, you can see right at the time of public reporting, the curves start to diverge a little bit. Massachusetts treating fewer patients with acute myocardial infarction than other states. That's the other states that surround them specifically. Now, the question is, well, are they just, kind of trimming the fat? Are they not treating patients who are futile, or not treating patients who are, kind of an acute myocardial infarction, but just a mild troponin bump and feel fine? Who are they not treating? And what does that mean for the health of that population, right? And so when she looked at it, if you looked at all patients with acute MI, there's no statistical difference in their in-hospital mortality among patients in Massachusetts versus surrounding states. So that kind of suggested, okay, they're treating fewer patients, but the outcomes are similar. That's good, right? There was, however, a 35% increase in the odds of death if you had a STEMI in Massachusetts or New York relative to other states. So sicker patients doing potentially less well in a public reporting state. But this is a little bit of an exclusive cohort, right? This is just people who have Medicare. So we actually repeated this study looking at the national inpatient sample, so it's everybody and we compared Massachusetts and New York, public reporting states, to a bunch of surrounding states that don't publicly report. Maryland, Vermont, Rhode Island, New Hampshire, so on, Connecticut, so on. And there's about 90,000 patients over these couple of years. And it just so happened, kind of by chance, that Massachusetts and New York had sort of proportionally fewer patients with cardiac arrest or cardiogenic shock, right? So slightly fewer really sick patients than the surrounding states. That was just happenstance, but it informs what happens next, which is that we found the overall mortality, in-hospital mortality, if you have a heart attack in Massachusetts or New York, was significantly worse in Massachusetts, in public reporting states than in non-public reporting states. Right? About a 22% increase in the odds that you die from your heart attack in public reporting states compared to non-public reporting states, despite the fact that the public reporting state patients tended to have a little bit less shock and cardiac arrest. Right? And when we subdivided a little further, you could see if you got stenting, same is true of CABG, I'm not showing it to you, but it's true. If you got stenting in a public reporting state, you did really well, right? But if you didn't get stenting in those states, you did really poorly. And the aggregate effect was that the public health of patients in public reporting states was worse, right? This, to me, suggests that we're cherry-picking who we're treating, right? There is this concept of risk aversion, that we don't want to face down necessarily the hardest scenarios because we don't want that to reflect back on our scorecards in those states. This may not be conscious, may be sort of unconscious or subtle, but I think that's what that data may show. So people started to catch on to this, and in 2006, Massachusetts actually stepped up and said, we're worried about this idea of risk aversion. We're going to introduce this thing called compassionate use. It's a data element that we'll put into our risk models. It is risk-adjusted mortality after all, so there is a risk model. Maybe we can tinker with the model to make it better. So they said if you have these very specific criteria, if you have, if unclear coma presentation, unclear neurologic status, we'll give you a bit of a pass for that. If you have CPR at the initiation of your PCI, we'll give you a pass for that. Or if you needed a pump, like a heart assist device, because your body was not capable of maintaining a blood pressure, then you can take those cases and you can submit them to our group of doctors. We'll review those cases, and then we'll tell you yes or no. Yes, you meet criteria or you don't. And if you do, then we'll give you an extra little checkbox there that we'll throw into the risk model. Right? And what that did was that it took a handful of cases down here, and it changed them from a predicted risk of mortality around 10% to a predicted risk of mortality closer to 70, 80, 90%. Right? So first, and most of those patients, by the way, were dead. Right? Dead is yellow. So it did affect the risk models. It sort of fine-tuned the calculations a little bit. More importantly, however, I think it built some trust between the people who are doing the reporting and the operators who are doing the cases, right? It let people think, at least, that they were being heard, that they could say, hey, listen, this case is harder than you think it was, and you review it and buy that idea. And what happened in Massachusetts? Well, so here's the introduction of compassionate use in 2005, and the rates of PCI for cardiogenic shock started to go back up. CABG stayed the same. There wasn't the introduction of compassionate use risk modeling for bypass surgery. It was just for PCI. And you can see that these rates start to go up a little bit. Right? So maybe people are starting to buy this idea that someone's listening, that they are not being, that things aren't strictly punitive. New York, however, went a step further. They said the risk models are too hard and they're really labor intensive. You've got to pay a bunch of physicians to review all these cases. Hospitals have to submit their data. It's laborious. Maybe there's unfair, a hospital that has a lot of ancillary staff might be able to submit cases for review easily. A hospital that doesn't have a lot of ancillary staff may not submit as many cases. Maybe there's, the application of compassionate use is not fairly distributed. So what we're going to do is we're going to say, if you meet specific criteria for cardiogenic shock at the time of your heart artery stenting, we're not going to consider that person in the public report. So what gets presented to the public will not include that patient. We'll analyze them, we'll look at the aggregate data, but not that person, right? And then they went one step further and they said, if your patient died of hypoxic brain injury, we'll do the same. And the reason for that is, a lot of these patients come in, they've just had cardiac arrest, they're intubated, you have no idea if they're brain dead or not, and you're left trying to decide if the brother who says, I gave him great CPR is telling the truth, right? And so it's a time-sensitive and difficult scenario, so they said, if there's hypoxic brain injury, we'll give you a pass on those patients too, okay? Not for nothing, in 2011, Pennsylvania stopped its public reporting process. I actually called the guy who ran the public reporting process in Pennsylvania a couple years ago, and he said, well, we were worried about our risk models. We didn't really believe them. We got a lot of pushback around them. So we sort of stopped the program, and we'll see in a few years if we can refine things a little bit. And this is a real concern, I think, in general. This is a scientific statement by the American Heart Association. It was published a couple years ago, where the American Heart Association has really been strong on trying to foster resuscitation centers, like centers of excellence for cardiovascular care. Such centers routinely get the worst patients transferred to them, right? And so as the American Heart Association is trying to foster this idea of cardiovascular resuscitation centers and high-end centers, public reporting represents a bit of a challenge to that. And so they actually looked at this, and I'm going to summarize for you, and they basically said, given the data that we have and how we risk adjust, there's insufficient granularity to understand cardiac arrest in particular, right? There is a single checkbox that just says cardiac arrest, yes or no. That's it. You don't know whether that person, when you're looking back at the data, trying to do the statistics, you have no idea if that person is someone in this room surrounded by 60 doctors who's going to get immediate great CPR and go downstairs within 5 minutes, or if it's a 90-year-old lady who slumped over a little bit more in front of the Price is Right. You just don't know. And so as you're trying to tease that apart, you just can't do it with the data, right? It's insufficiently granular. And so you could be a statistical genius, you could be a mathematical wizard. It's that idea of, poop in, poop out kind of concept. If the data is not granular enough, you just can't do with it what you want. Right? So they went on to say that they recommended, this writing committee recommended, that patients with cardiac arrest be not publicly reported in public reporting states. In other words, if that is your condition, just leave them aside. It's only 3% of the total PCI volume in general anyway. You still have 97% of patients to consider. It's probably enough, right? This has not been adopted in any public reporting state so far. It's not done here. It's not done in Washington, in New York or in Massachusetts. So, one of the things about cardiac arrest and shock patients, it's really simple math, right? If you look at the national data around elective PCI, there's an expected mortality of about 0.2%, 2 in 1,000 patients will die following elective PCI, theoretically. If you look at STEMI, right, we often consider STEMI to be sort of this really exciting, high-risk scenario. Mortality consistently year in and year out is about 5%. Right? And so 50 out of 1,000 patients will die. You can't see these colors at all, but take my word for it that they're there. And they look much better on my screen. But then you get to shock. The expected mortality is about 50%, right? Cardiac arrest and shock, 50% mortality, give or take, right? So that's 500 out of 1,000 patients. So if you're a busy cardiovascular hospital and you do 1,000 elective PCIs and 100 STEMIs a year, that's a robust number. You'd expect about 7 deaths a year, roughly, 0.6% mortality, give or take, using national statistics. If you add into that 14 cardiac arrests per year, you have just doubled your expected mortality, right? It's a 1.2% increase in your volume of patients and a 100% increase in your reported fatalities. These patients have an amazing amount of influence on your aggregate statistics, right? And you can track that, you can project this out depending on how many cardiac arrest patients show up. If you don't have 1,000 elective patients to sort of buffer your statistics, say you have 500, now you're really talking about an enormous effect of just a handful of patients on what we consider to be a quality indicator, right? So lots and lots of your patients in lots of settings do really well. A couple of patients do poorly. That will really affect things. And this, I think, leads to some physician tension, right? You have an ethical obligation to provide what you believe to be the best care to the patient in front of you. But consciously or unconsciously, there is this idea that you don't want to be considered bad. You don't want people to think, oh, don't go to that hospital. That's where everyone dies, right? I saw that on the newspaper. So there's your reputation, your hospital, your program's reputation that people consider whether they want to or not. And I think that's what the Massachusetts and the New York data have told us. I'm going to give you a case example. This is my case. For those of you who don't recognize what this thing is, that is a mechanical chest compression device called the Lucas that is currently on the EMS rigs in Seattle. This patient showed up in Harborview. When I got called and arrived, he already had this Lucas in place. He was already in the cath lab. And what I knew about him was that he was a middle-aged man who had been at the Sounders game with his teenage son, who was outside in the hallway crying that I had walked by, that he had a VF arrest in the field, and that he got pretty quick CPR from folks at the Sounders game and was brought over to Harborview, right? At this moment in time, this angiogram, here's our catheter. These are the coronary arteries. His LAD, the artery, the front wall of the heart should go right there. It's missing. At this point in time, all I've done is a diagnostic angiogram. He is not my patient. He's not necessarily my fatality, right? The second that I try and open up that artery, he's mine. Right? He's on my ledger. Now, you think he's going to live through this? Because I don't really. His chance of dying is really, really high. It's basically 100% if we do nothing. But this was the inciting event, right? He lost his left anterior descending and went to VF. The only chance he has for survival, in my estimation, is to open that artery and then work on mechanical circulatory support and other, cooling, et cetera, et cetera. But I'm now faced with a decision in this moment. I know that he's got a son a teenage son that's crying in the other room. I can look at his face and tell you that he's the age of anybody in this room. He could be our colleague, right? And he's dead. I mean, he's still dead. He's getting chest compressions. If I put that wire down his heart artery, try and open it up, and he stays dead, he will be my fatality. In the ledger books, his name will show up, my name will be next to it, he will be dead. And it is not hard to transition, I think, for people who don't understand statistics, etc. It's not hard to transition from the guy that died following PCI to the person you killed with PCI, right? It's not a big turn of the corner there, conceptually. Nobody else is looking at these pictures besides us in this room, right? There's nobody on the public reporting committee who's going to go and look at the angiogram and say, oh, God, that guy was dead, or near dead, or, that's not how it works, right? So these are difficult scenarios to decide what to do. We went ahead and opened his artery. There's his LAD where it's supposed to be. It didn't ultimately help. He died, right? He's my death, and I am perfectly fine with that. Some people, I think they deserve the chance. I think this is what we do. It's our job. But there's a lot of disincentive to treat these patients, and lumping more disincentives on there by having someone, kind of looking at your mortality statistics, it's a hard position to be in to a degree, right? So here we are in Washington State, started public reporting, 2012 data. First release of the data is in 2013. You can all see it. It's on cope.org. There's about 52 people who have actually looked at the website. Nobody goes there, but it is available. So we've talked about the potential pros in the beginning, just briefly, right? This transparency, building trust, Hawthorne effect, promoting best practices, really important things. Now we've kind of looked a little bit at the risks, right? One that I haven't talked about: unmeasured quality parameters are ignored. If this is something that is not, the STEMI example is a great one. We all looked at door-to-balloon time forever. How you got access to that artery probably has as much impact on mortality benefit as how quickly you did it. Nobody cares about that because it's not being checked, right? So unmeasured quality parameters generally ignored. There's this potential for upcoding in gaming. Everyone's playing the game, right? Trying to make your patients look a little sicker so that their expected mortality goes up, which drives down your observed to expected ratios. There's overemphasis on a physician, right? If you have a shocky patient, particularly someone who stays in the hospital a week, they may have as many as 40 or 50 physicians and trainees and mid-levels caring for them, right? But they're ascribed to a particular individual. Now, maybe that person also gets too much credit when they live, quite frankly, but they also potentially get too much blame when they die. And then there's avoidance of high-risk cases, which I think I've shown, which is sort of my bandwagon and something that I think I've shown you some data around. So let's move on to strategies for improvement, and let's look at it through the context of Washington specifically. When we started public reporting, 2013, there really was no evidence for risk avoidance as far as we could tell. The statistics around revascularization for patients in shock or out-of-hospital cardiac arrest had been pretty static over the last couple of years. We don't know what they are now, but that is the historical baseline that we're working from, right? But when you look at the frequency of PCI for cardiac arrest per hospital, it gets a little more interesting. So each blue dot here represents a hospital in Washington State. The what was a red line here is the mean. On the y-axis is the total PCI volume of each hospital. On the x-axis is the percentage of those PCIs that had cardiac arrest when they presented. Right? So it's roughly about 3% of patients, give or take. And that's a consistent, in our state, it's consistent more or less nationally. However, these two hospitals, they're at twice the state mean of cardiac arrest patients. And this guy, if I can get it to go, there you go, that hospital the percentage of patients who get PCI for cardiac arrest is 7-fold higher than the state mean. Right? I'll give you a guess what hospital that is. Rhymes with Barber View, right? So, and if you look at the expected mortality of cardiac arrest patients when they arrive per hospital, you can see that they're quite different, right? This guy up here, that hospital, whatever it is, had one cardiac arrest patient, and the expected mortality of that patient was about 80%. Right? This hospital over here, or these hospitals over there, had a couple of cardiac arrest patients, but based on the data they input into the system, the expected mortality of those patients is 10% or so. Right? So when you take that a step further and then compare the expected mortality to the actual observed mortality, you get widely discrepant views. This one I actually cut off. It goes to 6.5. Right? The observed mortality is 6.5 times higher than the expected mortality. If I put it up there, you couldn't tell the difference between these ones. Whereas these hospitals down here are about half, right? So the observed mortality is half of what would be predicted by the statistical models. So now you've got a 14-fold difference in the observed to expected mortality across hospitals in Washington state. Right? Is this an indicator of quality? Is this just luck? Or is this a failure of our data? I don't know the answer. When we're endeavoring to report our statistics publicly, we're not trying to say to everyone like, hey, look at chance. There's so much chance in life, right? We're assuming that this represents quality, but on this subset of patients, on this little subset of patients with cardiac arrest or cardiac shock, it's really hard to know if that's true, right? 14-fold difference, a huge magnitude of effect based on your hospital. It's hard to believe that's not, at least to some degree, also data failure and or luck, just chance. Right? So these are what I would call exceptional risk scenarios. And I want to talk about them. They're uncommon and they're difficult to treat, first off. Right? That's that patient with the Lucas chest compression device. It doesn't happen every day, thank goodness. But they're really difficult to make better. They're poorly characterized given the existing data granularity. You have a single data element that just says cardiac arrest, yes or no. They're non-randomly distributed across hospitals. So you could say, well, it's a wash. If every hospital got the same number of cardiac arrest patients, then don't worry about it, right? Because they're all equal. But they're not all equal. They're unevenly distributed across the institutions that we're looking at. They're difficult, time-sensitive scenarios, as I've kind of suggested to you, and by simple math, they have really a disproportionate influence on the aggregate statistics of that institution, right? So these are a couple of cases that really move the needle. But, and I believe this, treatment is beneficial, right? Treating these patients is the best chance they have most of the time. There are clearly cases where futility is an issue, but not all of them, and it's really hard to predict who they are, right? So here's what I have published and believe are strategies to reduce risk avoidance as it relates to public reporting, and I think this is real. This is something that I just believe in as a way to make public reporting better, not only for the public, who theoretically want this, but also to build trust with the operators and the administration and have everybody kind of come to the same level, see eye to eye. So one, I think you need to look at everybody. When you're doing public reporting, you analyze all patients, right? So anyone who gets the treatment should be analyzed. But I think that censoring of certain patients out of the public report is important, right? So you feed back to the hospitals their data on everybody. You feed out to the public, data on certain patients, and I think there are some patients who deserve to be censored. Out of hospital cardiac arrest with unclear neurologic status, right? So this isn't, they VF, they got one shock, they're talking to you, talking about how much that hurt to get shocked, and boy, that stunk, and that person has a different mortality than someone who is intubated and obtunded, and you don't know what's going on, right? Refractory cardiogenic shock at the start of the case, not fluid-responsive cardiogenic shock, but real cardiogenic shock at the start of the case, however you might define that. I think those people deserve to be censored. We didn't talk about this at all, but there's really good data that the eyeball test works, that people who are turned down for coronary artery bypass grafting have a much higher mortality in the setting of stenting than would be predicted by typical risk calculators. That is the eyeball test, right? Evidence of that. a couple of studies suggesting that as well. So just another measure that there's insufficient granularity in our risk models. But I think you have to go a lot further than that. Statistics are great, but they're only one part of the story, right? If you want to really build trust with the public around public reporting, then you can't just say, look at this blip on our radar screen. We did some math. This person was, hopefully not this person, this institution had a higher than expected mortality outcome. What do you think, right? You shouldn't stop there. So I think that from there, the next step is to have an independent review body go to that hospital and evaluate them, right? And then what they find in that evaluation should be part of the public report, right? That's how you build trust. Hey, we found this hospital. Statistically, it wasn't doing great. This body came in. They said, here are 4 changes. These are the 4 changes. Here's our action plan for that hospital as we see it as the public reporting agency, right? That's, I think, that gives the hospital, it's not just a stick. It's not just, you're bad, beat them over the head. It's, here's a way to get better, A. And B, I think it builds trust with the community to say, we're not just showing you that it exists. We're going to tell you how we think it can be made better. The issue with this is it's really labor intensive and it's expensive. Who pays for that is a big question. In Massachusetts, each hospital is ponying the bill for that of their own accord. It does not come out in the public report. And in fact, in all 4 negative outlier hospitals in Massachusetts, they've all paid for the American Medical Foundation to come in and review their practices, and all 4 have been absolved of poor quality. There are some accounting things at some of them, but basically in all 4 hospitals, the AMF sort of said, I think it's sort of bad luck and chance, right? And that does not end up on the front page of the Globe, right? You can't undo that first headline. So, and then lastly, I think there should be a consortium of public reporting agencies. We've got currently three states reporting on risk-adjusted mortality: Massachusetts, New York, and Washington. We all do things entirely differently, right? Massachusetts adds this data element to their risk models. New York censors out some patients. Washington does none of that. So there are lots of other states that have that have declared their intention to report risk-adjusted mortality following cardiovascular procedures. There's no reason they need to repeat the wheel, from my estimation, right? So getting together a loose consortium, some kind of network of public reporting, I think is beneficial to each state as we move forward, so that the public health is not affected by, experimenting with public reporting, particularly in ways that may, where the experiments have already been done in other states. Now, one of the big criticisms of talking about exceptionalism or leaving behind some cases is that people say, well, you're just looking for, you just want to get out of jail free card, right? Not every kid who runs a race deserves a trophy. Like, you're either good or you're bad. Do your job, And I think I understand that as a concept, but what I would say to you is this: where people were abusing the system, putting in too many stents, those were elective scenarios. Those were, healthy people. There is nobody who wants to be up in the middle of the night, who wants to be treating dying people, who wants to face down a crying family and tell them, I'm sorry, you put your hope in me and I failed you, right? Nobody wants that. There's tons of disincentive to treat high-risk patients. We don't need more disincentive to treat high-risk patients. That's just human nature, that people don't want to be in those really difficult scenarios because they stink, right? You lose sleep over them. I lose sleep over them anyway. And I think that's just being a normal human being, right? So I don't see this as a get-out-of-jail-free card. I mean, I think that PCI in shock, STEMI, and cardiac arrest is indicated and it's beneficial, right? Evidence, I believe, suggests that physicians are starting to avoid high-risk cases in public reporting states. They don't want to be perceived as poor performers. What I think our goal should be is to preserve the value of transparency but reduce inappropriate errors of omission, right? So that the public health gets the treatment that they need. All right, I'm going to end there, and left just a couple of minutes for questions, but I'm happy to field any.